Good morning. I'm Pat Croce, and this is the American Cancer Society's HEALED Community Gathering. HEALED is an acronym for Health and Energy Through Active Living Every Day. Thank you for joining us, and I love to thank our presenting sponsor, 6ABC, and you can always see this video not only on Facebook and YouTube, but on 6abc.com, where the entire library is located. Thanking our leadership partners, all those 30 individuals who helped pony up a good amount of money so that the research in Atlanta is going on, the HEALED research, and for each and every one of you who have gone to acshealed.com and made a donation, just a donation, a contribution to this great cause, and in return received our bracelet with the one green bead that signifies we're all in this together, the beingness with which we all exist, with a smile. We start this community gathering each and every week, and this is our 26th week. And I love it. I love our guests. I love all those who have been involved, as well as the ripple effect, who we get emails and questions and comments from. Thank you. The community is forever growing. We start the gathering with a moment of stillness. You might call it silence, spaciousness, beingness. And all I do is ring this little bell. And all you have to do is place your attention on the sound of the bell. You can keep your eyes open or close them. For those of you who've never meditated, you just did. That's all meditation is placing your awareness in the present moment on purpose, without judgment, without expectations. Whatever comes, comes. Whatever goes, goes. We just let it flow. And that's what we're going to do this next hour. Our community gathering is 1 hour long, and we have some great guests. And this is the first time we have a clinician and her former patient as our guest. And it's the first time we've had a physical therapist. As a physical therapist in a previous life, a couple lives ago, I am really honored to have this physical therapist on, because I only got a Bachelor of Science in Physical Therapy, and I specialized in sports medicine. This physical therapist took it all the way out. And I would like to introduce to you, her name is Dr. Nicole Stout. She got her physical therapy degree at Slippery Rock University of Pennsylvania, her master's of physical therapy at Chatham University, her clinical doctorate in physical therapy from Massachusetts General Hospital Institute of Health Professions, and she has a postgraduate certification in health policy from George Washington University School of Public Health. Oh my goodness. She is presently the research assistant professor of the School of Medicine, Department of Hematology Oncology at West Virginia University Cancer Institute, and the associate director of the Survivorship Program, and the author, and this is really cool because any question you have, this guest will answer. She's the author of 100 questions and answers about lymphedema. Please welcome with me, Dr. Nicole Stout. Hello, Dr. Stout. I ran out of breath.
Good morning, Pat, and thanks so much for that very kind introduction. I'm thrilled to be with you today. Thanks.
There was paragraphs of all the awards you received from the Navy Surgeon General and the National Institutes of Health. Before we talk about the field of physical therapy, what kept you going? There wasn't a PhD when I was doing it back then, but what made you keep on going from a clinical physical therapist to an expert in cancer rehab?
That's a great question. And you're right. The evolution of our field is sort of a driver. That, when you find something that you just love and you have such a passion for, I think you can appreciate that. And you're just inspired to continue. You crave the knowledge and you crave the experience. And that's first of all what led me to cancer. And once I found oncology rehabilitation, it was this eye-opening experience of, oh my goodness, the aha of what we can do to help restore function, mobility, activity for individuals going through cancer treatment was remarkable. And to be able to further my education to not only use my background and skills clinically to help people, but to really develop a line of research. And that's really what's been a driver for sort of the latter part of my career, knowing that clinically these individuals can benefit so much from rehabilitation services, exercise, but knowing also that rehabilitation is somewhat diminished in oncology care. We're not at the forefront. But to be able to develop an evidence base that's helped to move us forward and help to put this on the radar of oncologists and surgeons to say, hey, there's benefit here. Our patients can really benefit from exercise and rehabilitation interventions. So it's been driven by making change to take the field forward and to really elevate rehabilitation and integrate it into the oncology care continuum. That's been a big driver for me.
I
Passion.
love that. I love that you have the urge to fulfill that drive. But I want to go back just briefly to something you said. When I found oncology, like what did you find?
Right. So as a physical therapist, when you go to PT school, you don't really, you learn a little bit about oncology, and it's, you learn about all the contraindications and the things not to do with individuals who have cancer from a safety perspective. And at that time in the 1990s, when I was in PT school, there really weren't big oncology rehab centers around the United States. So I came out of school with my master's and I went to Penn. I started my career at the Hospital of the University of Pennsylvania, 3624 Market Street, outpatient physical therapy. And what a great experience there to be exposed to so many different areas of practice. And the Cancer Institute then at Penn was looking to develop a cancer rehab program. And I knew nothing about oncology at that point. And when I took the plunge, sort of leaping into starting to learn about this area, lymphedema was really where I started. I went for training for lymphedema management. And
Okay,
I
stop.
Yeah.
Stop. No, this is too good. And I'm going to interrupt you at times because you may be
That's
using
fine.
words that people don't know, but you found lymphedema kind of turned the corner for you. What exactly is lymphedema?
Yeah, lymphedema is an unfortunate side effect that some individuals experience after cancer treatments. Predominantly, it's associated with having lymph nodes removed, which is a common part of cancer surgeries. We take out lymph nodes to learn if the cancer cells have started to move throughout the body. When lymph nodes are removed, your lymphatic system is it's like the plumbing system of your body. And as you can imagine in your house, if you would disrupt the plumbing system, there's a risk that you could get a backup of fluid somewhere, and that's what can happen as a side effect of taking those lymph nodes out. So this backup congestion of fluid leads to swelling. It can be anywhere in the body where lymph nodes are taken: arms, legs, face, chest wall, genitals. We see lymphedema anywhere in the body. So there are specific interventions that you learn, strategies for lymphedema management with specific modalities like manual lymph drainage, compression bandaging techniques. And we put this all together in a system of care really for lymphedema management.
And did you do this at University of Pennsylvania?
I did. I was a part of the team that really started the program there. We had a physician, we had an inpatient oncology physical therapist in Laura Packle, we had a physician in Dr. Andrea Cheville, myself and another therapist in the outpatient division, Sarah Stolker and Nicole Dugan. We really started this lymphedema program, which evolved to a bigger, broader cancer rehabilitation program. And there really wasn't anything like it in the country at the time outside of the Memorial Sloan Kettering or the MD Anderson. It was really one of the first. And I always say that's why I feel like I've become the expert by default, because there just weren't a lot of people doing what we were doing at the time and seeing it to the volume that we were seeing it, the magnitude of patients that we were seeing. So it was really a time when there was an emergence of understanding about cancer survivorship and the needs of survivors, an emergence of understanding about rehabilitation and exercise and the benefit that it could afford to those patients.
Since you were a pioneer with lymphedema and cancer rehab in general, where was the research that you were using for protocols, for best practices?
Well, there wasn't much. And so we at Penn, because we were seeing these patients, I developed a research protocol there. We almost did such a good job at Penn. In rehab, we commonly focus on post-injury, post-traumatic rehabilitation, right? Somebody has a problem, they come to us and we fix it. But with cancer, from the very beginning, we know that patients will experience a number of different treatment modalities that can incite side effects that have a negative impact on how they function, how they walk, how they do their daily activities. And so we said, if we get people earlier, before they really have disability or limitations in their activities, we can do a better job at helping them stay functional and have better outcomes. So I started a pilot protocol there with prospective surveillance using a physical therapist early, almost immediately post-operatively, before people really get into the chemotherapy, the radiation therapy, and the other downstream treatments that cause negative side effects. And we found that by doing that early, it really contributed to better patient quality of life, but also better function. And so when I presented that work initially with our pilot study, some really important folks at the Department of Defense and the National Institutes of Health said, hey, we're trying to set up a protocol just like that. Would you be interested in coming to Washington, D.C. to work in the Cancer Institute at what was then the National Naval Medical Center and run this protocol? So I took that leap. And in 2004, I left Philadelphia, which is still in my heart. But I went to DC, and I was the PI then on two large longitudinal cohort studies that looked at using a physical therapist in the Cancer Institute from the point of diagnosis and following them all the way through the cancer continuum to reassess for early identification and early management of all of these functional issues that people face. Pain and swelling and limitations in joint mobility and dizziness, all of those things. If we're able to identify them early and manage these conditions early, first of all, our patients don't suffer that functional decline or the disability later down the line. We also found that by using rehab early, there are many, many side effects that we can actually prevent. So it was a different model at the time. It was novel. It's not typical in rehabilitation or in PT, right? We usually wait until there's impairment and we fix it. But this was a prospective surveillance model. So I ran those studies for the next 10 years. And that's how I developed the research line of this prospective, proactive engagement for individuals with cancer.
So can you give us some of the prospective surveillance model techniques or questions or tools that you used?
I would love to. This is, my heart, my love is prospective surveillance. And so really the prospective surveillance model is about methodology, standardized methods, starting at baseline, getting a baseline assessment of any individual at the point of diagnosis before they start treatment. Because guess what? Last week, that person was working full time. They took their kids to school. They played around golf or tennis, or they went to the grocery. This week, they're diagnosed with cancer, right? And so they're in sort of their normal physical activity, physical functional state. What a better time for us to know functionally, physically, what that person looks like before they start all these treatments that we know will have negative impact. So baseline assessment. Mobility, function, activity. What types of things do you do in your day, your workplace? Do you need assistance with things? So we start there. Cognition, weight, just function. And what we do is we follow people and we just repeat those baseline assessments at intervals throughout treatment. 1 month after they start treatment, 3 months, 6 months, 9 months, 1 year. And then we follow them yearly out after that. And we just repeat from baseline. And guess what? We identify the early onset of impairment that tells us a story about the potential for functional decline. And if we catch it early, we can minimize many of those longer term late effects and their negative impact on function. So prospective surveillance is, in our studies, we used a physical therapist. We could identify lymphedema at the swelling that we talked about at the earliest onset. We could identify predictive factors in blood markers and in functional in a patient self-report that were associated with disabling fatigue. We would introduce an exercise program. We were able to introduce range of motion, flexibility exercises early so that individuals going through radiation therapy would not lose mobility, postural exercises to help restore and maintain function. So the model itself is really a method, a different standard of care to introduce these functional aspects of working with these individuals and maintaining function throughout the duration of cancer care. It was really a different and novel thing at the time. And I will tell you the good thing. The American Cancer Society in 2010 came to our research team and to several other individuals and said, let's take this another level up. And they sponsored an international consensus roundtable on prospective surveillance. That was Dr. Robert Smith, who is still with the American Cancer Society in Atlanta, Kim Andrews, who was a phenomenal supporter of the program, and Dr. Katie Schmitz, who was also at University of Penn, myself, and Dr. Joe Binkley in Atlanta. So we spent 2 days with a subject matter expert group talking about the evidence, developing the model. And that was published in 2012 in a supplement to the journal Cancer, a full supplement, 16 articles that provide you the framework for the model and the evidence to support all of the various elements of the prospective surveillance model. And since then, it has just really kind of taken off as a new way to approach rehabilitation for individuals with cancer.
So, Nicole, that is my question. I mean, I love this because it's healed before,
Yes.
as soon as they get the diagnosis, healed health and energy through active living every day. Dr. Erica Rees-Pania's research is after they've been diagnosed because she states that 75%, 3 out of every 4 cancer survivors don't do enough after cancer treatment, and they sit on the couch. Now, you're talking about even before treatment. So I want to know how welcomed, how frequent, how user-friendly is this prospective surveillance model implemented, manifesting throughout our country?
It is very easy to implement. It takes a team, right? It takes I'll go back to your green bead, right? We're all in this together, and it takes that perspective and that approach. And unfortunately, I would say we're not at a level where this has become an integrated standard of oncology care. There are some centers around the country that have been very forward thinking, have brought in that therapist. The University of Utah, Huntsman Cancer Institute, they have a phenomenal clinically integrated physical therapist. Belmont Hospital in Michigan has developed a prehabilitation and prospective surveillance model. There are pockets around the country, NYU Langone, their cancer institute as well. There are pockets around the country where this is emerging. But I would say it is, it's not easy to integrate a new service. Oncology care is medically driven, of course, and necessarily so. But we've done such a great job of treating cancer, increasing survivorship. The problem is these individuals who survive their cancer diagnosis, they do so with high levels of morbidity. Like you've just suggested, 70% don't move enough. Part of that is because as they go through treatment, they're just not given the license to move. We tell them things like, you should just rest, or they try to keep up with that recommendation of moving 150 minutes of exercise weekly, the ACS guideline, the American College of Sports Medicine guideline. But then they have pain, or they have joint mobility, or they start to have swelling, or they have neuropathy, and they say, oh, should I keep moving or should I not? Should I push through this or should I not? That's when the therapeutic intervention with a rehab specialist is outstanding. So I feel like everyone needs to exercise, needs to move. There's good evidence to support that. But when you run into barriers that are going to put you on the sofa because you're fatigued, you're in pain, the rehab medicine provider, the physical therapist, can help get you over that and keep you moving so that we don't have this large disability burden. I mean, it's substantial. When we look at survivorship, greater than 60% of individuals who survive cancer have at least one impairment that prevents them from getting through their activities of daily living every day. And that's a big population. It's 17 million today. We anticipate it to be around 30 million by 2040. That's a lot of people. That's a lot of disability burden on society that we have the potential to prevent with movement and rehabilitative exercise.
Dr. Stout, Nicole, if you may, you sound like where I was in the early 80s, late 70s in the sports medicine world as a pioneer, because after surgery, most people didn't do anything. Or if they sprained their ankle, they were casted as opposed to contrast baths and taping and exercise. You sound like cardiac rehab is in the initial stages, and that I believe that anyone who's had orthopedic surgery in sports medicine needs a physical therapist, at least to get on the right path and to precondition prior to surgery. You're saying the same thing now to cancer rehab, cancer surgery, cancer treatment, to be prepared. And we've had guests on who've taken it upon themselves to be prepared for surgery, to get in shape for surgery. Is there some way that we can bang the bell so that everyone knows exactly what you're sharing right now?
Yeah, so there are some policy drivers, and this is, you reflected on my CV, the postgraduate certificate in health policy, was because we published all of this great research, right? The evidence base, and it wasn't being implemented. Well, what the heck? Why not? Because there are not policies in place that facilitate ease of access to rehab services, payment for rehab services in oncology. So over the last 8 years of my career, I've really spent working on special projects, running consensus meetings with experts, through special programs with the National Institutes of Health around cancer rehabilitation so that we can influence CMS, the Center for Medicare and Medicaid Services, help to influence their policies to implement and integrate rehabilitation prospective surveillance. We've developed, practice pathways. I'm on a working group right now with the World Health Organization to review guidelines around the world, oncology guidelines, and highlight where rehabilitation recommendations are made in guidelines so that we can better implement this into oncology care. We do have a big bell to ring right now because in 2020, the Commission on Cancer, which is a part of the American College of Surgeons and accredits cancer institutes and cancer centers around the United States, elevated rehabilitation, first of all, to a standard. So you have to have a rehabilitation referral source in your cancer center to be accredited. The other thing they did was, yes, exactly. Yes, hallelujah, right? Sing it with me. And that's a driver because right now people are figuring out how to do that. And, we're holding out prospective surveillance. In fact, prospective surveillance was one of the things that was cited as an optimal framework by the COC. They've also developed a construct for survivorship programs that encourage rehabilitation and physical therapy to be a part of any survivorship program, which I believe also is critical. So the more places that we can look to intercede with our services and our professionals in the cancer care delivery continuum, what we can't continue to do is expect that they're just going to refer them to PT, refer to rehab, send them off to some site, 3 blocks away, or make another appointment. We need to be co-located in the center where cancer care delivery is happening. Put us at an interface with the patient while they're going through treatment. They don't have time or energy for another appointment. do the consultation in the Cancer Institute. It's the most effective and efficient way, and the patients love it. They love having that contact right there in the Cancer Institute.
The KISS principle, right? Keep it simple, stupid.
You would think, but you and
Perfect.
we have a biased opinion in rehab, right?
So let me just, before I let you go, because you're going to have to take a little rest, although I have a dozen questions for you. One thing you mentioned was the minimization of side effects with cancer rehab prior to chemo or radiation. Can you identify some of those side effects so that our listeners understand the benefit of cancer rehab?
Okay, absolutely. So thinking about cardiac complications that frequently occur with adriamycin, for example, there's great and emerging evidence that exercise during chemotherapy can help to mitigate the consequences as it impacts the heart and heart failure.
Okay, everyone hear that. That's real. This is
Yeah.
the first time I've heard this.
Huge. That's huge. I can share with you, there's a fantastic research group out of Memorial Sloan Kettering that's doing great work in looking at reducing cardiac dysfunction and cardiotoxicity through exercise. Peripheral neuropathy, something that occurs very commonly. It impacts your sensation, but it also impacts your balance. Individuals who have cardio or neurotoxic chemo agents, cisplatin, carboplatin, oxaliplatin, any of the taxane drugs, Taxotere, Taxol, your balance will be disrupted after you going through cancer treatment and beyond. Sometimes your balance will be disrupted, and that persists for years afterwards. Rehabilitation can help to restore your balance, can help to prevent the balance deficits from becoming so severe that you trip or fall. We have about a 3-fold increased risk of falls in individuals who have a history of having these neurotoxic chemo agents. So rehab has a huge role to play there in early identification, balance exercises, lower extremity strengthening exercises to help to prevent that downstream sequelae. So those are just two examples of two very prevalent impairments that that can be very disabling if they're not managed over the course of treatment, so that we can prevent some of the downstream late effect.
Dr. Stout, this has been a fabulous conversation. Yeah, you have such a wealth of knowledge. I'm going to just ask you to sit on the sideline for a brief moment while we bring on our guest, who happens to be a former patient of yours, right, at the University of Penn?
Yes.
And
One of
so
my dear, yes.
we're going to bring on Toby now and then bring you back to share the screen with both of you. And if there's any questions from our audience, but I don't know if they're going to have to bud me because I got 1,000 questions for you. And since you wrote the book, I want to hear your answers. Thank you, Dr. Stout. Thank you. We'll be right back.
Thank you.
My next guest is, as I just said, a former patient of Dr. Stout's. Her name is Tobi Goldberg Maguire, and she's a retired researcher from the Abramson Family Cancer Center, and she's a breast cancer survivor. I'm going to let Toby tell her story, and in her story, in her journey, you're going to hear words that are going to be brand new to you. Activities, I might add, that she's a pioneer where Dr. Stout's a pioneer in cancer rehab. I think Toby's a pioneer in taking post-cancer to a whole different level. Toby, welcome.
Hi, nice to see you.
How you doing?
I'm okay.
So there was your former physical therapist on. How about her?
I'm almost in tears. We bonded so totally. When she was taking care of me, she was such an advocate for me to recover, to get back to dancing, which I was doing a lot of then, and just to feeling better. And I wish I could jump through the screen and give her a hug.
Well, maybe one day you can. But Toby, before we touch on your breast cancer diagnosis and your follow-up treatment plan and your resuming activities that are so unique, tell us about your research.
Research at Penn?
Yes. Well, the research that you're a retired researcher at Abramson.
Okay, so I was in a virology lab in the laboratory of James Allwine, and we did research on various types of viruses. And I grew tissue culture, which is growing cells in artificial media, and then we would put different viruses on them and learn about how the viruses affected the tissue culture. I worked with a microscope. I worked with my hands. And
how long were you in that field?
Well, I worked for Jim for 27 years. So, and even a little bit longer than that. So I was in that field of doing research for a long time.
Were you in the research field during your diagnosis?
Oh, yeah. And so this was, I guess, a silver lining. So my research I did at Penn, and all my treatments were at Penn. So after I was having visits, after I was starting to recover and stuff, and I was back at work, I could run over to my many appointments, go from the lab, go to my appointments, and come back. And that was including going over to the physical therapy area and working with Nicole.
So let's just stay there. So you were diagnosed with breast cancer in what, 2001?
In 2001.
And then when did you start your breast cancer or your cancer rehab?
I would say probably 8 to 10 weeks afterwards. I can't exactly remember. It was a long time ago. I had 2 lumpectomies, and they found cancer in 2 different places. So then I didn't have any choice but to get a mastectomy. And this was all picked up on a routine mammogram. So, hey, a shout out, ladies, be sure to get your mammograms, because if I hadn't had a mammogram, I would have probably been dead from cancer.
So, Toby, are you saying that in 2001, prior to the diagnosis, that you had no pain, no indication
Correct.
that you had breast cancer?
Correct. Yeah, they picked it all up on a mammogram. I didn't have any symptoms at all.
And not only 1 lump, but you had 2.
Right. So the first one they found was underneath my arm, and I still never felt it. And then the second one was more towards the front. And they picked that up on an MRI, I think. But I had a couple of biopsies before it was decided that I had to have a mastectomy.
And the entire treatment plan included what?
At that point, really having the mastectomy. Oh, and so I had Tram Reconstruction, which Nicole can.
Would you repeat that? What was that? Tram,
TRAM, truncal something or other. I can't remember all the words, but basically I had a tummy tuck, in a sense, from one hip to the other, and they take out the fat and the tissue, and they took to reconstruct a new breast, and they took the 3 of the 6-pack and tucked it underneath my rib, in a sense, to give blood supply to the new breast. And so the Tram Reconstruction was probably more difficult to recover from than the mastectomy itself. But it was a decision I made because whatever, that's what I decided to do.
And there were side effects from that surgery,
So
correct?
the Tram Reconstruction and this tummy tuck, that was when I started getting truncal lymphedema, which at that time wasn't well documented. And Andrea Chevelle, as she mentioned, was my rehab doctor. And so we started we tried all sorts of different things. Physical therapy was one of them. Nicole taught me to do lymphatic massage, trying to redirect the lymph fluid into other vessels that were still working.
So stay with that. Stay with that lymphatic massage. What exactly is that? How do you do that?
I think it's different for different places. If you have arm lymphedema, you work on your arm. So this was working on my trunk and trying to massage my underneath my trunk and down into my pelvic area. And
that's because you had swelling throughout that area.
So we were trying to redirect the lymph system and get it moving again. We had a hard time controlling the swelling, and ultimately I tried some other things. I don't know if you want me to get into that now, but
well, yeah, no,
okay.
Please. Did you have compression dressings or anything
I
else?
had, oh my God. I was wrapping myself in gauze. I was wrapping myself in ACE bandages. I had a compression vest that a company made that I actually wore when I was flying for a while. I wore bodysuits. What else did I try? Long length bras that go down to your hips to sort of contain all of that.
How about Toby internally relative to hydration or nutrition?
I don't think that had.
Not at the time.
I don't think so. But I was raised by. I was raised by a dietitian. My mom was a dietitian, so I would say that nutrition and hydration, I kind of knew how to do. So I think I was eating pretty healthy. And
you would think, most people would think if you have lymphedema and you have swelling that you shouldn't drink, that you really want diuretics, which is just the opposite.
Right. And I never tried. I never did that. And so eventually, Dr. Chevelle and I talked about all these different possibilities, and I still wasn't getting much relief from the swelling. And I went into an appointment, and we both at the same time said, well, maybe we should try Reiki. Reiki is an energy healing system that Reiki means life force, and it's an energy healing system where a Reiki practitioner guides the energy from the universe through the patient and helps to try to move stuck energy around. And I had known about it because I had taken a class. There were some healing nuns in Fox Chase, and I had taken some classes in Reiki and also something called Healing Touch. So I called the nuns and I made an appointment with Sister Sheila, and she worked on me for a whole session, and maybe I went back one more time, and the lymphedema in my mind started to subside, and I don't have it anymore. So I am assuming that helped move the stuck lymph around.
So wait. So let's stay there, Toby. So after you got this Reiki treatment from the sister, and however long it took afterward, you felt improvement. Did you continue taking more treatments?
No. I just did those two because my objective was to just get the stuck energy and lymph moving. And once it started to move and I stopped getting this truncal swelling, I didn't feel the need to go back there again.
And what did you do to continue the movement?
Eventually, I joined a dragon boat team, and that was one of the silver linings of having breast cancer.
Okay, wait a second. Okay, so you had a Reiki treatment or two. This got the movement of the lymph going, so the lymphedema started to shrink a little. Did you continue with compression dressings or anything else during this time frame? Massage?
Again, I don't think I did. It's hard to remember. It was 20 years ago, and I don't have the timeline quite firmed up in my head. I certainly tried to be physically active after like the 8 weeks or something that when I was just rehabbing from the surgery. I've always tried to be physically active, and in the beginning, it was hard for me I was angry at my body for betraying me, and it's because I had cancer. And so I needed to get back to feeling physically better, and did things that would try to increase my energy
Such
level.
as what?
Well,
This
trying.
is what Healed's all about. Health and energy
Yeah.
through active living. So give us, how did you become active again?
Well, one of the things I did a lot was contra dancing. It's similar to square dancing, and it's up and down in long lines. And that was something that I really wanted to get back to. And so one of the things I started doing again was going back to contra dancing and English dancing and Zydeco dancing and swing dancing. And that was my reward for getting better in a
And
sense.
how'd that work?
Well, I kept dancing and kept getting better, I think. I got my energy level back. It took a while, probably.
So for you, for better, I just want to make sure the clarification of better for you was swelling is going down, energy level is going up.
Yes.
Attitude and emotion is at a higher frequency.
Absolutely. And that was probably the biggest thing, because as I said in the beginning, I was so depressed, I guess, because I felt like my body had betrayed me.
Okay, so now we go from Reiki, we go from cancer rehab to Reiki to Contra dancing. Give us now dragon boat racing.
Okay.
What exactly happened here?
Okay, so
I love it.
I had a mutual friend who knew somebody on a breast cancer dragon boat team. And there had been an article in the Inquirer maybe 6 months before I was healthy enough to go back and do any activities about this dragon boat team that a woman, Fran Brazo, had been on, and it was helping her with her emotions and stuff, and also physically. Anyway, so my friend Nan got in touch with me and said, hey, yeah, you should come out and try dragon boating. A dragon boat is a long, narrow boat shaped like a canoe. It's 40 feet long. It holds 20 paddlers in 10 seats sitting next to each other, and you paddle right or you paddle left. And so somebody said, you know, what, you should go and try that. So I went out. It was on the Schuylkill River. I went down to the East River Drive and got on the boat, and I loved it. I've driven by the Schuylkill River forever. And I was like, oh my God, I'm in the middle of the Schuylkill River. I can't believe it. I've been driving down here all my life, but I've never been in the middle of the river. And it just grabbed me right from the beginning. And I became a part of Hope Afloat, which, as I said, is a breast cancer survivor dragon boat team. And everybody on that boat has survived breast cancer, but nobody needs to talk about it because we all know we've been through it. What we talk about is, you know, getting our timing down, going to races, enjoying being on the water.
So, Toby, can I ask you a question? All of you have been diagnosed with breast cancer and had some form of post-diagnosis treatment, whether it's radiation, surgery, chemo, or all of the above.
Yes.
And now you're going into something very physical that requires the chest, the lats, the axilla is stretched. Did you have the range of motion, and was it pain-free at the time?
I had the range of motion after by then, because Nicole had been working with me to get my.
Well, that's important. That's important
Yes.
to say here, because you were prepared to be able to dragon boat race. You were be able to row.
Yes. And where was I going with that thought? Dragon boating. Anyway, it was.
I was asking if you had the full range of motion and were able.
Yeah, and I did, and I could. Certainly, as I did more dragon boating, I got stronger. And I had gone from not being able to turn my body because of the surgery and the pain and the recovering from it, to being able to go like this. And I really feel like being on that dragon boat helped me to get my faith in my body back, and helped me to get my strength and my mobility back.
And so how do you feel right now?
I feel great.
I love those 3 words. So do you feel you have full range of motion now of your core?
Oh, absolutely.
Now, and you're not only your shoulders, but that looks beautiful. But how about your core, your trunk?
Yes. Yeah. And I'm continuing to stay physically active. I go to a gym twice a week with a trainer, and in between times try to get out and walk at least. Dragon boating's over for the season, so I'm not doing that right now. But I do always try to stay physically active.
Are you going to resume dragon boat racing when it comes back into season?
Probably, every season is well, do I want to do this again? But I really love being out on the water. It's just exhilarating to be out there with your teammates and gliding along the water.
I got to give you credit for pioneering, where we had a pioneer in Dr. Stout, but you also pioneered your own rehab program in the sense that you tried cancer rehab, which was new at the time, 20 years ago. You also wanted to resume your Contra dancing. You also tried Reiki treatment, a different form of massage, a more transcendental form of massage, and then dragon boat racing. So I think you're like a
Thank you.
dictionary for don't rest, move. See, you're perfect. You're like a poster child for healed, because that's what we're trying to get everyone to do, Toby, is to get and move, and don't be satisfied if you're not satisfied. That's the key. You weren't satisfied with your body. You felt that you were sabotaged by your body, and you were going to do something about it. Whereas most people just sit on the couch and throw up their arms and become complacent. No, I think it's wonderful.
And I have to put another shout out to Nicole, who I love, but she really was such a huge advocate for me, not just about raising my arm, but giving me the motivation to go back and doing my things. And when the Dragon Boat team raced in Washington one time, she actually came out and watched us race. She was just, as I said, I wish she were closer, and I wish I could jump through the screen and give her a hug.
Well, let's Toby bring her back on screen so you
Okay.
can give her a virtual hug.
Okay.
Oh my gosh, it's so good to see you. It really just invigorates me to hear your whole story again, Toby, and to see you just doing so well and thriving. It's really that's what cancer rehab is all about. All of it.
Yeah.
Toby, do you have any questions for Dr. Stout?
No, except when are you coming to Philadelphia so I can see you?
I know, right? Oh my goodness. But Toby, your story just characterizes every aspect of it through that whole continuum, why it's so important for us to engage rehabilitation early. With patients going through something as extensive as breast cancer treatment, a Tram Reconstruction, we should be walking alongside of every patient using rehab services to help get them over those humps, those swelling, those pain, those mobility. Really, that's the whole purpose. The rehab should get you to the place where you can dance, you can paddle, you can move, and you can be active. Without that rehab intervention, who knows where we would have landed with the ability to get back to where you are right now, the ability to get to where you are right now. So you just so beautifully characterize how rehab is a facilitator of an active lifestyle and exercise and movement.
Thank you. As I said, Nicole was a huge motivator and a huge cheerleader for me.
I can see why. But I got Dr. Stout, I'd like to ask you, because you're the author of 100 questions and answers about lymphedema. Can lymphedema be prevented?
That's a great question. We get that one a lot. I will say everyone's lymphatic system is different, right? We all have different capacity within our system to handle fluid volume. And we don't know what that is before we start messing with it. So we don't know what people bring to the table as their baseline capacity. So there are some individuals for whom we take out 30 lymph nodes and they never experience a problem for the entire life. There are some individuals for whom we take out 2 little lymph nodes or 3 with a sentinel node biopsy, and they develop lymphedema that's progressive and aggressive. So can we prevent lymphedema? Well, not only does the surgery incite lymphedema, radiation therapy on top of that does tissue damage that causes sclerosis to the lymph nodes, so further disabling the system. Scar tissue can inhibit, as Toby experienced. I think a big part of her lymphatic swelling in the trunk was because of the extensive scar tissue that she experienced, which inhibits those lymph vessels. So it's multifactorial. And I truly believe there are strategies through prospective surveillance, early intervention, where we can identify it at its earliest onset. And we can use strategies to prevent it from worsening to a more disabling stage. But I don't think we will ever really prevent lymphedema until we stop taking out lymph nodes, which is just it's a standard of care for staging cancer, and we need to know those lymph nodal status to be able to develop a care plan and to apply the correct treatment. So there's risk for anyone who's had lymph nodes taken, but using a prospective approach, we can catch it early. We can do education like manual lymph drainage to help redirect fluid pathways, to help with absorption, to help to reduce the risk.
I think your prospective surveillance model should be implemented everywhere with everyone. Do you feel that if Toby had this prospective surveillance questionnaire, or that maybe some of the activities that she eventually came to be might have been incited a little earlier in her treatment plan?
Yeah, I mean, I have to say, Toby and I connected rather early in the trajectory of her care. And that was because she had some incredibly proactive physicians. Her plastic surgeon, Dr. Lou Bucky, was incredibly amenable to sending her to rehabilitation. Not all plastic surgeons are, they want, well, let's wait, let's let it heal. Lou was a very early and active supporter of rehabilitation. Dr. Cheville, Dr. Andrea Cheville, was in the Cancer Institute facilitating patients getting in early. So I would say at the time, this was before there was really a prospective surveillance model, but I would say at the time, Toby really was, I would say, as close as we could have gotten to an early intervention model. And you have to remember, this was in the late 1990s, early 2000s, when we really, again, we're not using rehabilitation proactively. The procedures for breast reconstruction have come a long way since then. We don't harvest as much tissue. We leave the muscles in place. We take the fat. So, at the time, I think we got Toby very, very early. And she was also, the other part of this, as you know, Pat, and many know, the patient has to willingly participate. So there has to be a motivation and an interest. Part of my job, I think, is to catalyze that. If someone is quasi-motivated towards exercise or mobility, to encourage that in them and to encourage them to, when Toby said, I want to dance, I was like, great, let's figure out how to make it happen. I want to paddle. And, we spent a long time in cancer treatment telling women with breast cancer, don't lift more than 5 pounds for the rest of your life. And now we know that that's garbage advice. In fact, it does them more harm. So at that time, we were sort of in this tipping point with our knowledge and understanding of the safety of exercise. And when Toby said, I want to paddle, I was like, great. Let's get the mobility. Let's get you the strength. Let's make sure your core is in good shape. Because I think that was one of your first concerns, Toby, was if I have to paddle and I'm paddling on one side and I'm rotating, do I have the strength in my core? Can my reconstruction sustain that type of force? And I remember us having that discussion and, me really giving you license and saying, yes, you can. So advocating for you, supporting you, but also helping your knowledge and awareness to grow. I think that's really what the rehab provider does, in addition to all of the, getting your joints, getting your balance, getting you exercising again.
Toby, Dr. Stout said something really, really vital to all successful candidates that go through rehabilitation, whether it's cancer rehab, orthopedic rehab, cardiac rehab, is interest, your intention. Your attention and motivation starts with an intention or interest. Where did your interest come from that you wanted to get fully rehabilitated?
Well, my dad was a jock. My dad was a physical fitness nut. So I kind of grew up with physical fitness around me, I think. And I loved dancing. And I wanted to get back to doing something that I loved. And that was the motivation, I think. Also, I don't really like to be dependent on people, and I wanted to be able to get back to doing stuff for myself, being able to go to work and go to a dance and go to a meeting, and I wanted my energy and my physical fitness to get back to the level that it had been.
So if I might be able to reword this for my own and for our gathering audience, passion stoked your interest, freedom stoked your interest. You wanted to be able to be free and independent. At the same time, you wanted to do something and resume something that you were passionate about. So there were some catalysts for your intention, which drove your motivation. Therefore, you had attention to Dr. Stout's insights. But see, that's important because people fall off that continuum and go to the couch. You are a living role model, Toby, that it can be done. Where you place your attention is really, really important.
Thank you.
The other thing I'll tell you about Toby, if you don't mind, I'll share this little anecdote. As a scientist, Toby was also very committed to studying her recovery and her condition. She had a spreadsheet, and she did. And I hope you don't mind me sharing this about you because I loved this. I love
Oh, this is
patients
wonderful.
with level of motivation and intention. She would track her swelling. She'd track her waist circumference in the morning, in the afternoon, in the evening. She would document how her pants fit. She would document when she wore her vest at night, when she didn't, when she was in compression, when she wasn't. So that, again, I think it's just when we can work together like that as a team, me, therapist, her patient, but not just passive patient, active patient, right? Engaged in saying, oh, Nicole, here's my log from the last week. This is what's happened. Ooh, look at that. You really spiked on Wednesday. What did you do? Well, I walked, a little bit of a further distance, or I was standing longer, or I had to go in the lab for a longer period of time. So we really had an opportunity through her diligence and her meticulousness to problem solve quite a bit more, and probably got her to a better outcome because of that intention that she brought.
So with that attention, Dr. Stout, that Toby brought to her rehab program, one, you should bring her down to the University of Virginia for like a role model. But two, do you have your research candidates or your patients, clients log? Do they fill a journal?
Oh, I love using logs. I use logs for fatigue. I use logs for pain. I use logs for nutrition. I think it's incredibly helpful, not just telling me what you ate, how much you slept, how your fatigue level or your pain level was, but I like to understand what you did throughout the course of your day. So I think of the log as a day in the life. So you tell me, I got up in the morning, I made breakfast, I walked a mile, I went into work. Tell me the activities that you did throughout the day while you're logging and tracking pain, fatigue, your eating habits, your motivation, because that helps me. Sadness is another thing we use in the log, anxiety, stress. So I love that because it gives us a perspective on where there might be triggers of those side effects or those impairment. It also helps me think about strategies for energy conservation, which could be very helpful. If you're bunching all of your activities up in one part of the day, we can look back and see very clearly where those things are clustering that could be contributing to an increase in pain or fatigue or other symptoms. So I love the concept of activity logging and putting forward some metrics to that to help to identify severity impairment throughout the day.
See that, Toby? You're a pioneer that Dr. Stout can utilize.
And a pioneer. Yes.
That's very
Again,
sweet.
a pioneer.
Nicole.
So, Dr. Stout, one last thing. Our time is up now, but you've been such a wealth of knowledge here. Can you share with one secret that all of our community can utilize to make their cancer rehab just a little more, let's say, not enjoyable, but functional?
To make it happen. Let's be honest, to make it happen. I think if you are an individual who's experiencing cancer treatment, whether you're going through it now, whether you've gone through it in the past, or whether your loved one's going through it and you're a caregiver, ask your medical provider, where's my rehab specialist? Where's my physical therapist? I need to have that physical therapist on the team. And if they look at you crooked, you can do your own homework. You can find a therapist in your area. Moving Through Cancer is an initiative of the American College of Sports Medicine. Their website provides resources and has a registry. Find a PT, the American Physical Therapy Association has a website where you can identify your zip code and your diagnosis, and they will help you find someone who identifies as a specialist in cancer rehabilitation. So ask and expect that you should have these services as you're going through cancer treatment, because we do active living, healthy living, movement. Those are really the keys, not just after you're done with treatment to fix things, but during treatment to keep you active, to keep you mobile.
Dr. Nicole Stout, as a former cancer patient, as a former physical therapist, I bow to you. I love listening to you. Tobi Goldberg Maguire, thank you for being you and sharing your story.
Thank you.
I end every healed gathering, with just a little attitude of gratitude. It's a brief prayer, not a petitionary prayer, just of a thank you prayer. And it's just this: thank you for the grace in helping me to welcome what is happening right now. Thank you. Thank you, Dr. Stout. Thank you, Toby. Peace.
Namaste.
Namaste.